All right, everyone. This is Health Talk number 20 on functional medicine. And we have a special guest here with us today, Dr. Dan Stock. And Dr. Stock, I'd like you to introduce yourself and talk about functional medicine and really just what you see, the benefits of it, and the type of person it can help, and really what you see the role of functional medicine in healthcare moving forward. And everybody, we have about 30 minutes of discussion here, and then we're going to open it up for Q&A afterwards. So, Dr.
All right.
Stock, take it away.
I'm Dr. Dan Stock of Pure Health Functional Family Medicine, just north of Indianapolis. I think the first question that a lot of people want to know is, what is functional medicine? It's a nebulous term. It goes by two other names, by the way. It also goes by the name of integrative medicine and by the term of anti-aging medicine. I think probably the best way to describe it to people is getting down to finding the biochemical difference between you now and you when you were healthy. So to kind of get that so you get a feel, because that's a bunch of words that may not mean a lot. And what people need to know is how doctors are taught in medical school. Very little of what we learn actually goes through the biochemical processes that took you from feeling this way to feeling that way. What we got trained to do was do your physical exam and do some history on you to get a name on your condition. Once we got a name on your condition, and there was a list over here of things we could do that would make those symptoms go away. But the first step was naming the demon, and then there were things you did about that demon. What was never made clear to us in medical school was, how did the demon get in here? What brought him about? And it was never stressed to us that the things you're going to do on that list about the demon don't make the demon go away. They make the demon yell less loudly. So a good example, somebody comes in and they say, I have heartburn, doctor. And the doctor has been trained to say, well, is it worse after meals? Yeah, it's worse after meals. Do you burp and belch? Yes, I burp and belch. Okay, well, you have reflux disease, almost certainly. If you're you really thoughtful, play the odds doctor, you're going to say it's reflux disease and I'm comfortable prescribing treatment now. If you're a, hey, money's no object kind of doctor, then you're going to send that someone off to have a scope done. And then when that scope gets done, if it says, yep, this has got showing damage of the esophagus that is consistent with reflux disease, we're going to diagnose you with reflux disease, and over here is the list of medications that we're going to give you for that. And that will make this heartburn, which is what brought you to my office, go away. So what we're not taught to do in traditional medicine is to say, oh, so you have heartburn. Let's go into some more depth of that. Do you have burping and belching with the heartburn? No, I don't have burping and belching. I just have heartburn. Does it come on immediately with the meal, or is it like an hour and a half after the meal? Well, it's actually more like about an hour after the meal that it comes on. Does it get worse when you lie down? No, it's not really worse when I lie down. Okay, so the symptoms I'm hearing, let me do your physical exam. There's no tumors in your abdomen. The symptoms I'm hearing you tell me I'm not ready to do something about them because heartburn, that may be the name of the demon, but that doesn't tell me why the demon is in the room in the first place. So from your history and physical exam, I suspect that you probably have inflammation in your gut that is coming primarily from the gut. Let's make sure. Let me ask you some more questions about what kind of food do you eat? Do you have changes in bowel habits associated with this? Okay. So then when I've got most of this history done and physical examination done, I'm going to look to see what other things outside of the bowel could have made your bowel start having this malfunction. And as I look through all the things on the outside of the bowel, gee, do you have irregular periods? Do you have regular periods with breast tenderness and mood swings? Do you live in a moldy building? Is your mouth full of decaying teeth? Then I'm going to be able to put together the idea that, okay, you have inflammation of your bowel. That inflammation of your bowel is causing the mechanics of your gastrointestinal system not to work right, so that the valves aren't opening and closing like they should. And then to a lesser degree, it's causing a toxic effect on the lining of your colon so that your colon lining isn't very good. And that inflammation is what's making you have the symptom of heartburn or reflux disease. So now that I understand all of the things that are making you malfunction, I have the biochemical differences outlined between you before you had heartburn and now you with your heartburn. Now I can come up with treatments that will actually make your biochemistry go back as close as I can to you without symptoms. And that is usually going to lead to different treatments than what you would do if you just said, hey, you have this symptom, I've got the name on the demon, this medicine treats that symptom. So for instance, a good example, if you have somebody comes in and they've got reflux disease. So these guys all have heartburn up here. It comes on pretty quickly after a meal. They have burping and belching, gets worse if they lie down, worse with a larger meal than a smaller meal. If you look at the pathophysiology of this person, the inflammation of their gut is making it so the lining of their esophagus isn't very good, and the musculature that controls the valves in the system isn't working right. You'll notice nowhere in that pathology did I mention that these people make too much acid. So a clever question would be, well, gee, do people with reflux disease make more acid than a normal person? And the answer is they don't. Many times they make less. And yet every treatment that we have for reflux disease in traditional medicine works by reducing your ability to make acid. Well, does that make the symptom go away? Sure it does. Does it have any consequences? Well, you know what? It turns out that the good bacteria that live in your gut, they like acid. The bad bacteria that cause the inflammation in your gut, they don't like acid. So actually now what you've done is made the underlying disease process get worse because you've made them grow more bad bacteria, but they don't hurt now. Okay, well, does that have a consequence? Well, you know what it does. It turns out that people with reflux disease have a higher risk of autoimmune diseases, psychiatric diseases, dementia, cancer, all of the other consequences of inflammation throughout the body, which is upregulated when you reduce their acid production. So in the functional or integrative or anti-aging approach to medicine, we're doing that deeper dive. We want to get down to, okay, I don't care what symptom you have and what makes the symptom go away. I need to know the biochemical processes that made this symptom come on, and then I will choose options that will make that process stop and reverse, undo the damage that is done, and therefore I will have less effect on all the other systems of the body. So another thing that kind of defines functional medicine, when we're in our training, we kind of taught the gut has gut symptoms, the brain has brain symptoms, lungs have lung symptoms. What we were never taught was that, you know what, lungs can have diseases that make guts have symptoms. We were never taught that brains can have diseases that makes kidneys have symptoms. This was never really taught to us. So that depth of integration of when I act on, gee, here's the symptom, I may act on blocking the thing at the organ that's complaining, where actually the organ that's complaining is doing so because of a disease in a totally other organ. A good example of that would be high blood pressure. So a lot of people don't know that the bacteria living in the mouth of a healthy person make a chemical that's used by the body to make nitric oxide, which is the chemical that makes us relax our blood vessels. As a matter of fact, I can take a healthy human, and if I give them a bacteria-killing mouthwash for 5 straight days, I can raise their blood pressure 15 points over 7.5 points. A lot of people don't know that if you take a guy who has bad dentition and you put him on an oral probiotic to replace the bacteria that make the chemical you need to regulate your blood pressure, that you can lower blood pressure. As a matter, that's right. So traditional medicine says, oh, we're not looking at this very deeply. The symptom is blood pressure. You have high blood pressure. Here's a drug that lowers blood pressure. They have not been trained to or choose not to go to the level of insight to say, okay, high blood pressure means your cardiovascular system is misbehaving. Why is it misbehaving? Let's look for all the things that can misbehave it. Is it because of a brain injury? Do you have bad teeth in your mouth? Do you have a brain injury and bad teeth in your mouth? Do you have a hormone deficiency? For instance, testosterone and estrogen have both been shown that if you're deficient, they lower blood pressure under the right conditions. Rather than go through that, let's get down to the nitty-gritty, the biochemical difference between you before you had symptoms and you when you have symptoms. We just go down to the symptoms and go from there. And so that's basically what functional medicine or integrative medicine or anti-aging medicine is. It's just medicine more in depth. So how can it help? Well, it helps in several ways. First of all, you never notice when you get any of these things that traditional medicine does with these patent medicines. There's always a list of side effects that comes right after that commercial, and may cause blah, 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 blah. Well, when you get to the biochemical difference between you healthy and you sick, and you move them back to this, you don't get side effects because you're actually getting to the root of the problem. And the further you are away from the root of the problem, the more you're going to get side effects. The other thing that it helps is in prevention. So, for instance, we have wonderful research now that tells us that the underlying problem for nearly every chronic disease is either excessive inflammation or dysregulation of inflammation going on in the body. So it causes X, Y, or Z symptom, and we come out with X, Y, or Z symptom and make that symptom go away. But because we didn't stop the inflammation that brought on that symptom, the inflammation continues going. So the leading way it's going to kill you eventually is through heart attack and stroke, because that actually, believe it or not, is an inflammatory disease. It's an inflammatory system of excessive stimulation and excessive response to it. If it doesn't kill you that way, then it'll give you cancer. And if it doesn't kill you that way, and you live long enough, then you'll just get Alzheimer's or Parkinson's disease. So when you actually get to the root of the problem, the problem is that you have really lousy diet, you have bad bugs living in your gut and your mouth, you don't exercise about the amount the brain needs, and you live in a moldy building. And I get all of those things taken care of. And then whatever little processes they started in motion, I slow down and turn down, you prevent the other problems. So a good example of this, you say, well, gee, are there any things that if I develop asthma, are there any diseases I'm more likely to get? Why, yes, you're more likely to get dementia, you're more likely to get reflux disease. Well, if I have reflux disease, are there any diseases I'm more likely to get? Why, yes, you're more likely to get asthma and dementia. So if we act at the level of, hey, this is what made me get sick, if I stop the processes that made you different now than when you were healthy, I actually prevent other diseases from developing. Whereas if you just use a symptom blocker, well, here's your acid reducer for your heartburn problem, you actually don't prevent other diseases. And sometimes you actually bring on more diseases. So there's any number of treatments that have been shown that over long periods of time, they raise the risk of other problems. So for instance, the leading acid blocker drugs have been shown they hasten kidney failure. That's because acid deficiency was acid excess wasn't what caused the disease in the first place. Therefore, going after acid, doing your process of acid reduction doesn't stop the process and actually worsens the problem in that particular instance, because now the only way your body gets rid of acid, which was planning and putting out through your gut, it has to pump it out through your kidney, and now acid washes your kidney for years. So then when you get down to what do I envision functional medicine's role in the future being? I think what people are going to find out when they realize that our present healthcare system is actually just a profitable prepayment system for disease maintenance, we're going to find that they refuse this system and they say, no, I don't want the superficial analysis. I don't want to know what medicine will stop my heartburn symptom. That I want to know what caused my heartburn symptom and what are the things that I do to uncause my heartburn system. Now, some people are going to hear that and say, I don't want to change, I'll just die anyway. But the vast majority of people, when they find out, wait a minute, you mean this heartburn thing that I have is being caused by the food I eat and the fact that I smoke, and it's not just going to do this in the future, it's going to give me dementia and cancer and get my leg amputated and make me have heart attacks and strokes and make me spend tons and tons of money for more and more medicines as more and more things fall apart, then I think you're going to see people say, no, I don't want the superficial approach to this. I want the in-depth approach to this because I want to make things I want them to get well and get better. And that's where I see happening is that we're going to find people demanding a retraining of their doctors. It's not okay for you to get my symptoms, go to the list and find the thing that makes the symptom go away. Your job is to identify the disease processes that made me get these symptoms. And then you can tell me what needs to be done to reverse those processes. So that kind of in the nutshell is what functional medicine is. Now, it does entail us doing things frequently like using some supplements that you wouldn't see in medicine. So for instance, vitamin D lowers blood pressure, improves kidney function. Somebody says, I have back pain. Lo and behold, vitamin D treats back pain. Short-term solutions, we tend to use like a different thing. So if you come into me with asthma, you could say, wow, should I use Dalaresp? And I'm very likely to say, well, you could use Dalaresp, or you could use Boswellia serrata extract. That's frankincense, by the way. That's been shown to block the enzyme system that leads to asthma. Doesn't tend to have some of the side effects of the other medicines for asthma. It won't make you get thrush and things like that. And if it works, we can control your symptoms with that until we can get enough vitamin D and you get your diet changed, get you out of that moldy building, and make your immune system settle back down so it won't be reacting to things anymore. So there are a lot of other tools you can use because once you do functional, because there are a lot of ways when you understand the biochemical processes making it go wrong, sometimes you have to tack these in a particular order. And while I'm waiting to go through the order and get them all done, I may be using some things that don't make the process get worse, but they do help alleviate symptoms in the short term. But they have usually better trade-offs of risks and benefits than a superficially thought out treatment like, oh, your blood pressure's high, let me put you on something to make your blood vessels relax.
I have a good story about that too. And Dr. Stock, I appreciate the rundown on functional medicine. Very informative. Every time I hear about it, I learn more and more. I got a perfect example though. I had actually both of my kids, of course, they're 3 months old. They puke after they eat. That's just a fact of life. Our pediatrician both times prescribed a proton pump inhibitor for both of these kids. And I said, no, why is that your first choice is a pharmaceutical? Why? How about we just change the formula, change what's going down in their stomach every single 3 hours? That's my first step. It might be a problem with that. And I actually started doing some research, and there was a study came out a couple of years ago on the use of proton pump inhibitors in infants. And they have a 30% higher chance of breaking bones later on in life. That is not a risk I would ever want to touch. And, I'm trying to explain this to my wife, and she's a nurse, and she just believes what the pediatrician says. And I'm sitting here saying, no, we are not going to give this to our kids. Let's just change the formula. And sure enough, guess what happened? Change the formula. The baby stopped spitting up all the time. It's still spit up, and at the same time goes with time. And, she talks to other moms that have the same problem. She's like, yeah, they took Prilosec or Zantac and they stopped spitting up after 3 or 4 months. I'm like, that's just time. That's just what happens anyways. It's not saying that, solve the problem. And it just burns me up that all across the country, like how many extra broken bones are caused by, I'm going to call it negligence or laziness, or I don't know really what you would call it, by pediatricians prescribing stuff that does not have the kid's best interest in mind.
And I tell people, please understand the doctor who recommended that's the best she knew how to do because that's what she got trained to do in medical school.
Yeah, that's the same thing I'd say. Yeah.
And I'll tell you how the functional medicine doctor approaches this from the get-go. We look at biochemical differences. So we say, well, you have to understand one of the things that's different about formula and breast milk is that formula doesn't have any transfer factor or antibodies in it. Transfer factor is actually something made by the mother's immune system, which actually teaches the immune system of the baby what bacteria to attack and what bacteria not to attack and what should be living in your gut. It also makes it so the immune system in general starts to mature. And our response would be, well, is there a reason we're not breastfeeding in the first place? Because there are physiologic consequences to using formula instead of breast milk. And then we would say, have you thought about going down to the local breast milk bank? And maybe you can get formula from there. That will actually contain transfer factors and antibodies, and will start making it so that you get the right microbiome in the gut of your kid. After all, in an infant who's puking, it's almost certain that the wrong guys aren't living in there, or that the immune system who's supposed to interact with those guys hasn't learned how to interact and play well with them. And we're going to go to that level of, well, let's get that retaught, because there's stuff in formula that aren't in breast milk. There's stuff in breast milk that aren't in formula. And after all, that's what you were designed for. You're biochemically designed for the stuff in formula. Evolution did what evolution was supposed to do. But I always make sure that I don't want to beat down my traditional medicine colleagues. First of all, I know that in the present healthcare system, they'll be bankrupted if they start doing this. You're going to find nobody in functional medicine is taking insurance hardly at all. And second of all, they don't know what they don't know. It was very common in medical school that we would be told, because I was one of these pasty-eating geeks who would say, well, why does the stomach do that? Why doesn't that sphincter at the top of the stomach close? And they would say, well, nobody knows. And we would say, oh, nobody knows. I guess nobody knows. What they meant to say was, I don't know, all right? But there was somebody else who did know. You get once you get told nobody knows, you think you know that nobody knows, and you quit looking. You wait for a drug company to come out with a new drug that has a new, better way, that has fewer side effects to handle the symptom, because the physiology was very superficially taught to us in medical school. In fact, to give you a feeling for that, if anybody said, Dan, of all the stuff you know about thyroid physiology right now, what percentage of that did you learn in medical school? And the answer is probably about 1/8. And I had to throw out another 1/8 I was taught that was wrong. So 3/4 of what I know about thyroid physiology was just never taught to me. And another 1/8 of what was taught to me was wrong. It was just factually incorrect. I didn't know I knew all that stuff wrong until I started studying more about thyroid physiology in my functional medicine training. And so it's important to know that a lot of the problem we're fighting right now in this whole, gee, why are we traditional versus functional? Part of it's economic because it's just punished. But part of it is the doctor doesn't know that there's more he could know.
And adding to that too, they don't have enough time to research more because they have 7-10 minutes of the patient. It's just turning in, turning out. Right. You don't really have that time to re-educate yourself, to learn more, to keep up with the thousands of PubMed articles published every single week. So
right.
It's difficult.
I can tell you, if you go to the typical functional medicine doctor's office, your first appointment is going to be between 1 and 2.5 hours long. It's 2.5 hours in my practice, at least if you come in with diseases. I can probably keep it to an hour. If you come in and say, I got nothing wrong with me, I can keep it to an hour. Those are unheard of. No family doctor spending 2.5 hours with a patient is just, that would bankrupt a practice being done in the third-party payment system. And so you're right. The other thing that's causing this is right now, doctors actually, it is financially more expensive to learn functional and integrative medicine than it is to just keep doing traditional medicine learning. If you want to learn about the newest drug that came out from Pfizer, that's actually going to be paid for by the hospital continuing medical education system. And the board certification program that you're required to maintain so that you can take insurance and be employed by that hospital, they'll cover that and count that towards your required continuing medical education. But if you say, well, no, what I'd really like to do is to learn the functional approach to thyroid physiology. Well, that course is actually 3 times the price, and it doesn't count towards your board certification, so the hospital system isn't going to pay for that course, and so you actually have to spend that extra 3 times the price for that continuing medical education has to be taken out of your own wallet, taken away from the mouth of your family and your kids. And so it's actually financially disadvantaged even learning this deeper depth. Once you've learned it, though, you realize that a lot of testing you do, because I'm going to bet somebody who's going to watch this video is going to say, I went and did a bunch of expensive tests. And after I got through with all the expensive tests, they didn't tell me to do anything but they came out and said, well, we don't know. All the testing's negative. And I can tell you what you find happens a lot more in functional medicine is we sit around, hear your story, do your physical exam, and say, well, it's one of 2 things. So we're going to do these 2 tests here. One of the 2 of them comes back and tells us what to do about it. So we don't order a lot of different tests. Somebody comes in and says, well, I've got this pain here in my knee. And does it get worse when you use it? No, it actually gets better when I use it. Really? Let me push on your knee. Does it hurt when I push on your knee? No, it doesn't hurt when you push on my knee. Let me move your knee around. Does it hurt when I move your knee around? No, it doesn't hurt when I move my knee around. You know what? I don't think we're going to MRI your knee. I don't think the problem's coming from your knee. I think the problem's in your nervous system. It's running the muscles around that knee wrong. And so we don't order the expensive test. So we said, look, that's not going to help us. You know, if it were your knee were the problem, you'd have pain when I push here and pain if I do this. And I don't think that's what's causing your knee pain. I think you need pain someplace else, so we don't need to do the expensive test. And we just test people differently because we already know, look, from what you told me, the problem is probably not there. I understand the pathophysiology of this stuff, but the problem is over here, and that's where I want to test.
You know, right there, that mentality going into a diagnosis is, you could save the country probably $300 to $400 billion, easy, just with, hey, let's not do these tests. But the thing that always is lurking in the corner is the legal system. I think a lot of physicians, they just want to cover all the bases and just say, yeah, sure, we'll order this test, and this test, just in case I don't get sued later on. And I think that is a big problem in healthcare. It's been a big problem.
Yeah, and it depends a lot on the state you're in. And a lot of it, I think, depends upon the knowledge of the doctor. Like, for instance, here in Indiana, we have a wonderful malpractice set up. But there's still a lot of unnecessary testing being ordered. Well, why is that being done? Well, first of all, the doctor is not given time to take a history and physical exam and figure out where the problem probably is. Second of all, even if he did have the time to do it, he hasn't got the training to actually look that deep into it. And then thirdly, either the doctor or his boss, if he works for a hospital, makes money on every test he orders. Absolutely. And he has a quota that he has to come up with, all right? So the third-party payment system is actually making him do a superficial insight and then do a bunch of unnecessary. But this whole question of whether a test is necessary or not, that's very nebulous, isn't it? So, you know, we always have to we try to look at things that are graded problems, black and white. You know, gee, your knee hurts. Is an x-ray necessary or is it unnecessary? Well, the better way to look at that is, what's the percentage chance, knowing the information I know before I do this test, that the test is going to change what I'm going to do next? So when you start looking at this as a graded response, then it's like, well, you know what? If you don't have pain or anatomic abnormality of the knee itself, and you don't have movement pain when the knee is passively moved, then the reality is there probably is not a problem with the knee, or the chance that there's a problem with the knee is so small that now this black and white, necessary, unnecessary, well, it actually leads you to say, which would be better, that or maybe we look at your thyroid system and see, you know, there is a little bit of swelling at your ankle here. Let me check your Achilles reflex. You know, that Achilles DTR is kind of hung. Maybe the problem you're having is muscle spasm of your quads because if you have a thyroid condition that isn't working right. And the money would be better spent not on the knee x-ray. That's not going to change what I do, as likely as if I do my time and my money on the investigation of some thyroid labs. And so that's where every test you do that comes back with a negative answer is a wasted test. It didn't change what you're doing. And so, you know, when you know the processes, you gamble better with the money. And when you gamble better with the money, you actually spend less money. And I think that's actually a bigger problem than the malpractice fear is. I think if a doctor has paid directly by the patient, then he has a reason not to fear his lawyer. Because now he says, look, you know, if I use my patient's money to pay my lawyer off, the patient's going to get mad and leave. In a system where the patient doesn't have control over the money, well, you know, my lawyer becomes more important to me now. And so I think a lot of this isn't so much the malpractice, it's just that I have a quota of things I need to do and no time to think this out deeply. In fact, I read a study probably about 10 years ago now that actually showed 90% of all lawsuits are filed against 5% of all doctors. And those doctors on average spend 7 minutes or less with their patients. Right. And most of the time the doctor is acquitted. He actually hasn't done something that his colleagues would say was stupid. It's just the patient didn't trust him. And so I think a lot of the cost of healthcare isn't so much the malpractice fear. It's actually that we're paying doctors and training doctors to think superficially so they actually don't go try and get the best gamble of the patient's testing procedures. A great example of this, I have a gentleman I picked up in my practice, and I'm taking his surgical history. He said, yeah, I had a hernia repair. I said, which side? And he said, well, 3 times on the left and 3 times on the right. I'm getting ready to have the 4th one done on both sides because the hernia came back. And I'm like, man, did you like play tackle football every time and blow this out? Oh, no, they just broke one day. It's like, well, dude, look, before you have another hernia surgery done on the other side there's something wrong with your metabolism because you're not maintaining healthy tendons in your abdominal wall. What makes you think the 4th repair is going to do any better than the first 3 did? If you told me that somebody blew into your abdomen while making a tackle, maybe I'd accept that. But you had 3 hernias on each side came in out of nowhere without trauma. Guy, I got to tell you, there's something wrong with your metabolism. We shouldn't be fixing these hernias again until we have something figured out in your metabolism. And I can tell you that patient under investigation had a testosterone level less than the age of an 85-year-old man. So was his diagnosis a hernia? Well, I'm going to tell you, I don't think his diagnosis was a hernia. And I think if somebody would have asked him when his very first bulge developed in his groin, if they would have said, how did this happen? And if you said, well, I don't know, I just noticed it there one day. No trauma had occurred to me to make this happen. Well, we'd have said, I don't think the primary problem down there in the groin. So that's kind of the difference, I think, with the way the functional medicine approach. When you say, look, I have to know processes, that's what I have to know. Before I start doing stuff, I have to know processes. Which processes are probably the problem? Let me get an evaluation of those processes first. Then you do different tests. I mean, I know typically they say you need a hemoglobin A1C in a diabetic once every 3 months. My response is, well, I don't know why I need him that far. I'm going to figure out why this guy's blood sugar is out of control and find out whether he's going to do something about it. If the guy says, yeah, I'm going to eat better, I'm like, well, okay, I don't think I need a hemoglobin A1C every 3 months for the remainder of your life. Why don't we see what your fasting blood sugars look like here? You can do those at home. We'll see what they look like here in 3-4 weeks. Oh, those have gotten a lot better? Okay, well, I don't think we need a hemoglobin A1C right now. Your fasting blood sugars are down to 86. Nothing I'm going to do any differently because that hemoglobin A1C right now, I think we've got the problem taken care of. Or at least we're on the road to it. Maybe we're going to do this hemoglobin A1C another 6 months kind of thing.
I just shared an interesting link on medical malpractice to kind of go back to what you're saying there. And I think it totally, just the amount of medical malpractice lawsuits, the dollar amount, it's less than 2% of everything we spend in healthcare.
Yeah.
But you got to also think about just that small dollar amount also impacts the way we think.
I think the bigger reason that what a doctor is more afraid of when he orders a test right now is more afraid that his employer is going to say, oh, you didn't order enough tests.
Yeah.
He's more afraid the insurance company is going to say, I'm not going to pay for this treatment until you've ordered this test. The best example I can think of is, well, better get an x-ray on your back because I know they won't pay for the MRI on your back until I get an x-ray on your back. And I saw this on a patient of mine recently. Came in, it was very clear cut from his physical exam and history. The man had ruptured his disc and it was compressing his L5 nerve root. And called up to get an MRI. And the insurance company says, well, have you got x-rays done yet? Well, look, I've got a hung DTR at the guy's Achilles, and he's got no sensation all down the lateral side of his foot. And he's lost his strength in his knee extensors. And the guy has consistent pain that gets worse when he bears down to go to the bathroom. I don't think you're going to find anything in this x-ray. Nope, got to have an x-ray. Won't pay for his MRI. Okay, here's your x-ray. It's a total waste of this man's money. All right, but all right, we got to get an MRI so we know that the surgeon knows that you got the right level when he goes to work on this thing. So there's a lot of this that's being driven by protocols and lack of the understanding of process. Interesting, that same patient, when he developed his pain, he went to the emergency room the night before that, and the doctor didn't even do a physical exam or check his reflexes to notice that he had lost his Achilles DTR and that he didn't have extensor strength in his quads anymore. So there was no time to do all that physical exam and history on this guy. And so it got blown off completely. So a totally wasted ER visit, followed up by a wasted x-ray that was mandated by the man's insurance.
Yeah, I'm thinking of how AI can play a role in functional medicine. Now, do you see AI aiding you in terms of coming up with scenarios that could be possible? Or because I mean, there's so much stuff out there that could happen, and also some things that just will not happen based on the, the knowledge at hand. I mean, do you see having a tool to help you kind of guide you in your decisions?
Um, I guess I'm pessimistic about that. And the reason I'm pessimistic about that is because it's impossible to make that AI take a good history. And the example I always like to use to people is somebody comes and says, I have a cough. The first thing I do when they tell me they have a cough is, okay, do we mean, or do we mean, or do we mean like I got something in the back of my throat? Words themselves are very poor communicators. In fact, I saw a report that verbal communication is like 20% of communication, and the rest of the 80% is body language and facial expression and intonation. Well, that's really hard for AI to interpret that. And when you're trying to cut down the number of tests you do and get yourself into the right disease process, that ability to interact with the patient and understand this becomes the limiting factor. Now, if the doctor can say, okay, it really is, now he has to know, does that AI understand? Because I can't type into the computer. You know, if I just put in cough, does AI know what I meant by that? If I put in heartburn, well, you know, heartburn's different when it occurs 20 minutes after you begin the meal than when it begins an hour and a half after you begin the meal. This is very hard to program in. And I think by the time you got an AI able to handle this complexity, what you would have is the functional medicine doctor. And you haven't actually, there's so much learning that goes into this, how the symptoms develop and how you accept that this is the symptom is going to probably limit AI. I can tell you I was actually the pilot site for electronic medical record systems at the health network that I used to be employed by. And I saw these electronic medical record systems as useful data management tools for the physician. But what became was, oh no, we can collect these symptoms and make decisions on them for the doctor. And that's why you go in right now and you don't actually talk to your doctor. The medical assistant comes in and has you fill out all the check boxes of what all your symptoms are. But it doesn't work because I tell people that you just can't, the symptoms, the words that describe these symptoms, and what AI systems are good at doing is crunching words. But words are such a small component of our communication that you end up asking the computer to come up with a thing that it can be 90% sure of with 20% of the information. And so I think artificial intelligence systems are probably not going to add a lot to this unless somebody can make them get so much more sophisticated at interpreting things like facial expression and body language.
Well, I think we're already there with some of this technology. As far as voice goes, there's a lot you can determine from your voice, and we have these digital assistants all in your offices, at home, and I think they're going to play a much larger role in our health. As much as I hate it, this always on listening assistant, it can pick up tones in your voice. It can pick up those coughs that you're coughing, 4 hours every single night, starting at 3 a.m. in the morning. And the potential predictors, that could be monitored passively, and that could be fed into a data system where you can kind of pull information from that to make a diagnosis. And there's studies now that you can actually detect onset of Alzheimer's in somebody's voice.
And I don't doubt that, but let me point out why I think that's not going to be helpful. All right, so you can detect and say, I think this guy has Alzheimer's in his voice. Okay, that's great. You've named his demon. Do you know anything about how he got the demon there? Because unless you can do that, you're doing traditional medicine. All right, and that's the problem, because when I said, hey, look, or is this, The reason I said that was because in the back of my mind, I knew that there were different processes that made people have these symptoms. And I was already trying to figure out, was this coming from your sinuses, coming from your gastrointestinal system, coming from irritation in your lungs, or coming in your bronchi? And it was because I knew those processes that I knew to ask that defining question. It's going to be very difficult to make that come from a computer, because those processes are going to be extremely interactive. And if you want, I can send you a map that shows you what we have right now for the metabolic pathways that we have identified. It's a poster that takes up most of a wall, and it is so busy no human being can decipher it all on their own. To program all of that into a computer and then make it interface, because that won't tell you that this metabolism is going to lead to versus dry cough versus wet cough. You ask, oh yeah, bring stuff up. Well, does it come up with the very first cough? After 2, 3 coughs? After 4 or 5 coughs? These are all things that that you need to know before you do this. And so I'm a little pessimistic that AI is going to be terribly helpful. Now, what it might be useful to do is when the doctor gets the symptoms and does the physical exam, and that is extremely important as well, because physical exam, especially when you're examining a joint, has got so much to do with using it. It might be useful that when a doctor says, okay, I'm going to plug in the symptoms as I interpret them in the physical exam as I interpret it, and then maybe I'll get a list of suggested diagnoses which will stick in my mind to think about, oh, this process. But the very problem there is that AI likes to get names on demons, and getting the name on the demon doesn't tell you a lot about how he got there and how to get rid of it. So I'm a little pessimistic. I'm open-minded to it, but there's actually a group that was trying to do that with something called the Metabolic Code, which was a program that if you wanted to be a functional medicine doctor, you could get it and plug in the stuff. I looked at how it worked, and what I kind of figured out was, well, if you're a starting functional medicine physician, if you're somebody who's traditional medicine trying to become functional, maybe it speeds you up a little bit, but you're probably going to be in practice 2 years, and this thing's just going to slow you down and mislead you.
Yeah, it's interesting. I haven't heard of that. And I just shared one link. It's I guess it's Hummod or Humod, and it's kind of similar. They're trying to map out some models of really just human physiology. And I'm actually giving a TED talk before or after this guy. I got a choice, but I'm really interested to talk with him and kind of see what his work is, because it's pretty interesting to know somebody here in Mississippi is working on something like this. Kind of surprising. But it'd be interesting to see that. And I shared the link. I haven't done too much research into this, but just from surface level, look very interesting.
But, like I say, I keep an open mind. Eventually, we probably will have some analyzer that can collect this data and run it through there. After all, human beings' brains are just computers. The problem is loading in all of the data that makes the information that you're seeing right now useful. And my brother, who's an electrical engineer, his response to that question is, well, by the time you've taught the machine all of the knowledge in the doctor's head, you have a doctor. And unfortunately, the problem with AI is we have trouble getting it to learn all of the things at the speed that it doesn't learn it a lot faster than a doctor does.
Yeah,
so it'll be interesting. Like I say, I'm open-minded to it. Every doctor's job is to put himself out of business. So
it's going to be very hard to copy the human mind, or at least one up the human mind, because Dr. Alan Hand, it's a physician we've been talking to, kind of helping us out here. He said he is so good at diagnosing the influenza, that at the end of a year, after he's seen plenty of flu cases come through, he can pretty much determine whether they have the flu or not, and which strain it is, based on the smell of the person, their breath, their facial, just the color of their skin. And he said he can pretty much figure out which one it is. And that's amazing. There's so many different sensory inputs there that you're processing that. Yeah, it's going to take a while for AI to get there, but I think it is. I think it's inevitable.
Well, and another thing that people think when they think AI medicine is that they always associate it with diagnosis, but there's much more areas where AI can help. and not replace a doctor, but just help them. For example, a long time ago in medicine, what the idea of knowing that another similar case happened before, and maybe getting some information, some insight from that case and applying it to another case. Well, if we have an AI that kind of listens to what the doctor is saying and maybe mines around and brings that similar case that might have happened in Japan and translates it and gives you like maybe the procedure that the doctor went through to figure out what the diagnosis is, what's the source of the disease. It's going to be, of course, just an insight, not really a diagnosis. But I mean, it's something that can help a physician, in their daily work.
That's where I mentioned that, something which has the ability for the doctor to say, okay, look, I'll punch in the physical exam findings and the symptoms, and maybe I'll get suggestions that will be helpful. I think it's very unlikely that AI is going to be something which, it's probably going to, for weird cases, it may add something. But, if a guy comes in and says, I eat a high fructose diet with a lot of fat in it, and I have heartburn 10 minutes after I start to eat with burping and belching that gets worse on recline, I tell him, with that little, the time it would have taken me to put all of that information into the AI system, I already knew what was probably going on with this guy. And the question is how much time it would save and how much it would increase accuracy. The difficulty is the number of the variables. Most of these variables are not black and white variables. They're not dichotomous. They're not even linear variables. They're usually curvilinear variables. And the interactions between the variables are neither linear nor dichotomous. And many of them, we don't really know the nature of the relationship between the variables. We just know there is one. It's kind of hard for a computer to deal with a variable when it doesn't know the relationship between them. It just knows there is one. But I don't want to say that it's going to be of no value. Like I say, the metabolic code, when I looked at it, I said, yeah, I think it would have helped probably for my first year. But after my first year, it wouldn't have sped me up, and it wouldn't have made things less expensive and wouldn't have made things more accurate. Now, metabolic code may not be as complicated as AI can get. And like I say, I think we need to keep an open mind for that one. I think it's kind of, it becomes mind-numbing when you realize all of the different things that can go together as far as processes. And then secondary processes and tertiary processes, it can be a little daunting. I think most people who are trying to take this AI probably are not functional medicine physicians, and they don't realize the number of variables that they're not looking at, and the complexity of measuring that variable and knowing what it means. But, I think someday we probably do have, Bones McCoy's scanner. And that would certainly be a boon.
Let me ask you I'm sorry, Nabil, go ahead.
Yeah. I was looking at, I was listening intently all through this, and Dr. Stark, thank you for taking time to present on this. And, as a physician who is a sick care doctor, like I'm the extreme of the sick care doctors. I take care of sepsis and infectious disease and all the other things. And I see that the more complex problem is a simple issue of obesity. And 70% of my patients are obese, and trying to even, solve the complex problem of healthcare, which is 5 things, that is communication, personalization, and realization, implementation, and reevaluation. So, how can we go about making that a reality in this complex healthcare? We cannot train the doctors. We don't have enough number of doctors as committed as you to do that. And it becomes more complex as we are trying to deliver this complex service line, which is unique. And like we do studies which take us, say, we take 1,000 people and get a drug approved and try to apply it to billions of people, and this is so non-working solution. And that's where I see a process where we can create a system that will help the people empower themselves and try to help solve these 5 things that I talked, and just bring them to the front so that guys like you and me then can rake our mind to try to figure out which one is causing their trouble. Unless they collect their data, we can go in that metabolic pathway that you're talking about, and us trying to fix that problem without allowing them and using data or using technology to empower them, it makes it harder. I mean, like that said, I am totally agreeing with you, but also I'm saying that I see a huge difficulty, you see. I'm an infectious disease doctor, I'm a wound care doctor, I'm an board certified obesity medicine doctor. And suppose, think about it, my goal is to really set up a system of improvement in India in healthcare. Now, I chose wound care as my target to help India. And to even train, I've been in this thing trying to do this for 10 years. Since 2008, I set up an organization, Podiatry Association in India, and every quarter we train like 50 to 60 doctors. So I know about 2,000 doctors in India who do foot care, but 2,000 is minimal pittance in trying to deliver that solution back home. Now I'm building a solution that helps them recognize that problem, but then I'm having to build that solution. Now, how much can I give the knowledge to them? You know, the knowledge that I've gained over the last 15 years, I cannot be there and do that. Maybe if I build processes that this AI system can empower them, and so that then I collect the data and move them through this process where we create a system of identification and a environment or ecosystem wherein providers who are enlightened, then somebody takes a picture, and then somebody gives an opinion, and then we have a phased manner in which we can create blockchain technology to provide that solution, and then we can create a solution, economic model that supports itself. I mean, that's one of the reasons why I want to look into this blockchain as an idea. And I was amazed by what you said, though. I wrote it down: profitable prepayment system of medicine, the current kind of medicine. I mean, like, it's crazy nuts that we are doing this. But then I guess we don't know anything else right now, unless crazy guys like Brennan go and try to create a system that is going to drastically change it. And I would help do my part to make that thing happen. And I guess I will stop my rant right now.
So I guess I would respond to that is the most important change in the system is to get rid of it, because motivation is the first thing you have to have before education occurs. And right now our present system pays doctors much better if they think superficially than if they think deeply. It punishes them if they try and think deeply financially. And that's because the definition of good health care, what the money is going to get spent on, is being made by someone other than the guy on the exam table. And so the most important thing we're going to do, if we're going to have anything to do to fix the American healthcare system, is to take the money away from governments, insurance companies, employers, and give the money back to the patients. They are the guys who have to be in charge of this. They will then decide, look, I want a doctor who thinks as deeply as Dan does and his colleagues do. And then you will see motivation, and doctors will say, I will go do that. But right now, as long as the doctor is being paid third party, this is never going to work. Because that third party is always going to have a different definition of good health care than the guy on the exam table does. And it will always be inefficient and always pay that doctor to do something other than what the guy on the exam table wants. So that the reformation of the system is going to be the deformation of the system. Motivation has to come first, and right now we are motivated to think very superficially in the United States. That's how we're paid. In fact, I don't take insurance. Everybody who's in my practice pays cash. Most of them, very happy to pay cash. Some of them who don't even want functional medicine depth of thought, because it's cheaper for them to get traditional medicine through me than through the traditional medicine system. That's why I was telling Brennan earlier today is like, my favorite topic is actually getting rid of the third-party payment system, because it's what made doctors think superficially in the first place. We used to really care whether or not we were smarter than the guy beside us that ran rounds. Now we don't care. In fact, half of them don't even go to ground rounds. You see people in the CME activities and they're sitting around reading their newspaper. They're not even learning. And that's because the motivation is completely destroyed. The only way to fix that, give the money back to the patient. As I told Brennan, if we have the money back in the patient's hand, you're going to see functional medicine take off. Because at that point, patients are going to say, look, I didn't come in here, I've had strep throat 3 times in the last year. I don't want another amoxicillin. I want to know why I keep getting strep throat. All right? You're actually going to see the first time somebody comes in with strep throat and say, why did I get this? Nobody coughed in my face. I haven't been around anybody else with strep throat. Why me? These are the kind of questions that come to me. And I ask these people when they get their amoxicillin prescription, what's your diet like? Oh, well, you want to bet that your mouth is full of the bacteria that harbor and make you a good home for streptococci? We're never going to get that depth of analysis until the money goes back in the patient's hands. Because other than that, it's just quicker for me to think superficially. And I think it is management of the healthcare system which has made this big dichotomy between functional medicine and traditional medicine occur. I see no solution for it except getting the money back into the patient's hands.
The mentality is next.
Yeah, that's right.
Turn the crank.
When the definition of my job is done is being defined by anybody except the guy on the exam table, there is a problem.
Yes, sir.
Because I have people who define good healthcare very differently, even within my own practice. And until we have the money so that the guy who defines good healthcare defines it with his dollars, this system is not salvageable. We will always be traditional medicine doctors until that occurs.
Oh, I think the transition is occurring slowly. Slowly. Guys like you, the whole DPC movement, functional medicine, there's a lot of people out there that are taking a step of faith and getting out of the whole insurance game. And that's what it's going to take, is people just like you, kind of the pioneers, to go out there and say, all right, I see a better way. Nobody else is doing it. Let me do it.
And the emperor has no clothes. The guy, when I mentioned to him, why are you having that hernia surgery done? But the time he left the office, he was mad. He's like, now, why didn't that freaking surgeon, the third time why didn't he tell me that before he did that third set of surgeries? Like, well,
money, honey.
That's right. He gets paid more money to cut you than to think about you.
Right.
He makes more money in the operating room per minute than he does in his office per minute. So he wanted to cut you. He didn't know it. He didn't twirl his mustache and know that. He just, in the back of his mind, because the system says that cutting people's more valuable than thinking about people, he was doing this. So pretty quickly, the people begin to realize, the emperor has no clothes. And once that process, especially when it's expensive to go see the emperor and he's wearing no clothes, pretty soon people begin to get the idea of, I'd like to see somebody who's wearing clothes.
The question comes down to us then trying to educate that patient. How do you propose we do that?
Well, the most important thing is that the patient has the money. Because when the patient has the money, he's going to doctor shop until he finds the smartest doctor. There's nobody in my practice. There's nobody in my practice who saw me as the first doctor they saw. That's not what happened. They all saw some other doctor first. And they came to me because that guy didn't have a solution that they were looking for. They were not satisfied with their care. So the problem is we keep looking at this from the problem is the doctor doesn't know, and not recognizing that the reason the doctor doesn't know is because he's paid better if he doesn't know. As soon as the money is in the patient's hands, because we've cured an Alzheimer's patient now. So I tell that to one of my patients, and they're like, you know what? Aunt Minnie has Alzheimer's. Like, well, you go ask Aunt Minnie's family if she's happy to have the care she's having now, or would she like to hear more about this? Once the patient has control of the money, The doctors will learn because they can be paid to learn. But right now they're being paid to do what someone else defined as good healthcare, not what the patient defined. And everybody who wants to sit down and say, we need to educate the doctors, I tell them, look, the doctors are going to educate themselves when they have no choice to. But right now they have another choice besides educating themselves. And as long as we have a third party determining what good healthcare is, they are going to choose to learn that party's definition of good healthcare. And that will never be as in-depth as an individual patient's, because it's very different from patient to patient. I have a feeling John knows this pretty well, because I can see the look on his face. He's doing the, yep, won't work if the system. It's got to go back to the patient. Am I guessing right, John?
You got that right.
John designed the system.
Do you take insurance, John?
No, I'm not a doctor. First of all, I'm on the other side. I'm a recovering hospital CEO.
So you've seen the ugly from the other side.
I've seen the ugly from the other side, particularly as it relates to physicians that are employed and those that are independent. And that's why I'm nodding. You're absolutely right. You hit the nail on the head time and time again. Till we get the money back in the hand of the patient, who really should be the one making the decision in the first place.
That's right.
It's been usurped. Actually, the employers are partly guilty as well, because it's been what, 60 years when World War II ended and they had wage and price controls. That's when employer-sponsored insurance came on board as a way to attract employees.
Yep.
It's been going on a lot longer than people want to give it credit for.
And I think now you have to understand the employer, since they have to pay for this nonsense, their definition of good healthcare is whatever's cheap. I want less expensive. I don't care. I don't care if the patient feels better. But you're right. The problem is, you can say, back in the late 80s, the idea is that the doctors are all smart. We're going to have HMOs and they're going to take care of the patient. Yeah, really quickly what happened?
Took care of the money.
That's right. The doctor just took the money and ran. Yeah. At the end of the day, we have to recognize the fact that it doesn't matter if I know all of the chemicals that are in mayonnaise if the guy on the table doesn't like mayonnaise. All right. But the only solution to this is to put the money and the power back in the hands of the patient, because at the end of everybody talks about he won't comply. You know what? The reason he doesn't comply is he's powerless.
It's not his money either.
That's right.
If it's his money, all of a sudden compliance goes way up.
That's right. And there is, you've seen this, John, you already know this. I hate it when somebody says, gee, that nasty hospital. I say, do you know what kind of a financial gun that hospital has to its head right now, dude? I mean, they're just like the minor player in the Nazi party. You have no idea. I tell them the only way to solve this problem is we need there to be no Nazis. We need the money back in the patient's hand. And then this very complex problem that is solved by functional medicine will get solved, because the doctor will have no choice. They'll leave me if I don't. And you're going to see more and more doctors start knowing this because they have to. Any other questions?
Yeah, I do have a question for you. I took some notes here. I was thinking about at-home diagnostic test, Everlywell, for example. And this is one particular vendor that we're going to be selling their products to your patients who need them. And I don't know if you've dealt with them or you recommend anything for your patients, but that is one I had a question about. Are you familiar with it?
I don't know that particular thing, but I will make a comment right from the get-go. When you look at any product, whether it is a test or a treatment, the most important thing you need to know before you buy that product is some advice about that product. So one of the big ways that money is being made in functional medicine is testing everything known to man. If I sit down and take a good history and a physical exam, I probably already know what the results of most of the tests I'm going to do are. All right. So a lot of the tests that I see my colleagues doing that I don't do are because I don't make any money on that test. So before you evaluate, you look at, hey, wouldn't it be nice if the patient could get this product? The next question, before you even do that, has got to be, is that an advisable product for this patient? And that needs to be gotten from somebody who has studied this biology enough and doesn't have a dog in the fight. One of the things that's kind of unique about my functional medicine practice is I have a clause in my contract with all of my patients that I can make no profit on anything I give them advice about. Vaccine, medicine, supplement, lab test, radiology exam, referral. And one of the big ways I see money getting made right now is let's do a test on something that can't possibly be used to help the patient. One of my favorite examples is let's go test their MTHFR genetic status. I'm like, why? You're not going to be able to change their gene. You're going to get $40 out of them for the test. And we're going to say, oh, look, aren't you unfortunate? And we're going to put them on the same dose of methylfolate that we probably would put everybody in anyway, because the effect of that gene is not very great. And so when somebody says, boy, we have this product for at-home testing, what I see happening is somebody spending a lot of money for unnecessary testing. I just had a patient of mine wanted to have her HLA-DR genetic study. And I'm saying, well, you already have a negative visual contrast test. If it wouldn't it be good to know my genes? I say, well, those genes determine your visual contrast test. So now that I already have a negative visual contrast test, I can actually tell you what the results of that test is going to be. So when somebody comes out with another 23andMe that can tell me you ate your HLA-DR genes, I'm going to say, guys, I got that information a cheaper way by doing a free visual contrast test. And so I think whenever a product comes out for home use, the most important thing is who is going to benefit from that test, and that requires unbiased advice, and you will never get that from the guy who makes the product. He has an inborn bias in himself. And I have a lot of vendors who come to me and say, let me show you what my wonderful product is. Some of these really are helpful products for a certain segment of the population. But you can spend a lot of money if you're not in that segment getting a lot of testing done. What the favorite thing is now is to make sure everybody tests the same thing 5 different ways. You know, until you know the advice about each individual test and what you already know, it's really hard to make that useful. Now, that said, there are certain tests that you can do at home, like visual contrast testing. I direct my patients, hey, you know what? This is going to be worth, do this site here. If you pass that one, it's free, great. You fail that one, go spend $15 at this site. Now that $15 is going to be well spent. Should everybody go do the surviving mold visual contrast test? Well, unfortunately, only 1 out of every 4 people is even going to have the disease to begin with. And I can tell you that we're probably going to get a fair number of those people who are going to fall out doing the free test. And so I think at-home testing is a useful thing, but only with the proper advice to back it up. Otherwise, it becomes a financial boondoggle. And that from a guy who sees a lot of money get made doing testing.
Yeah, I didn't realize they had this many tests. I was just looking at it as you were talking. They have food sensitivity test, post-menopause, women fertility, HbA1c, heart health, cholesterol. They have about 30.
Right, you can go bankrupt paying for all of that testing. A good example that's food allergy testing. You know, somebody goes off and gets food allergy testing and say, well, is it IgG or IgM based, or is it a gamma interferon stimulation test? Well, it's IgG or IgA based. Okay, you realize there's a correlation, but it's not a strong correlation between that and food withdrawal. And even if we did withdraw the food, the problem can't just be that you have asparagus. After all, I eat asparagus and my immune system doesn't make any antibodies against asparagus. Why is your immune system malfunctioning? That's really the question. And so that assay, if you'd done that, really doesn't do anything to improve the patient's outcome. Unless you know that going in about the test, then you spend a lot of money on testing that's not helpful. I'm always happy that we have a market that makes testing available. I would just want no patient to go start doing a bunch of testing unless they got advice first, mostly because you're going to get a lot of financial hurt done that isn't going to help you. And you can get yourself really down a rabbit hole chasing down this thing, what you think is the problem, only to find out it really wasn't the problem. Oh, I have dairy allergy. Well, why do you have dairy allergy? After all, cow's milk doesn't kill a lot of people. Why is it killing you? So with that said, I think it's great that there are some, like a lot of the tests I do on hormones, I give somebody a kit and send them home with the kit. You're going to collect it at home and send it in. I think it's great to have that kind of stuff. It's actually better than if I had them come to my office and spit in a tube 4 times a day. But they all have advice before they walk out with that kit. And it's unbiased advice.
How much like a thyroid test here is for $159? I'm kind of curious. Is that about the same price, or I don't know if it's equivalent?
It depends on what all thyroid tests you're talking about. Is that covering a TSH, free T3, free T4, and a reverse T3?
It just says thyroid test. I don't know.
You got to be specific.
Yeah, so that's where the advice comes in. So I can tell you, I can get you a free T3, free T4, reverse T3, and a TSH in my office for $44.25. And I can tell you with those 4 tests, I probably know about 85% of what's going on in your thyroid system. Right from that. So again, thyroid test. Was this a good thing? Well, first of all, you need somebody who knows what else being tested in there. Let's look at all that chemistry coming through there.
Yeah,
the chemistry part gets tough.
Free T4, free T3, TSH, TPO. Yeah.
Yeah. So TPO, who cares about your TPO? If your reverse T3, free T3, free T4, and TSH are all in the optimal ranges, who cares what your TPO is? All right. So that's a good example of great that people, I am a big fan of patients being able to get whatever test they want. In fact, every patient in my office will hear me say this to them more than 10 times. I'll order whatever you want, but what's going to change the advice I give you is this and this test and not that one. And I'm a big fan that the patient gets the ability to do an at-home test. And I do believe that a patient should be able to order their own tests. I firmly believe that. But I would discourage any patient from doing that without some advice beforehand, because the complexity of this problem is so great. I can tell you there's no way that I am going to go in and modify the operating system of my computer till I call up my brother, the double E, and say, dude, tell me what I'm supposed to do here, because I'm going to launch missiles at Russia if I just do this by myself.
All right. Well, hey, Dr. Stock, we'll go ahead and stop the recording now. I think that was a pretty good health talk. So I appreciate you joining and your insight into functional medicine. And until next time.
All righty.